Thank you again, Sammy. And I will invite our panelists to come up, and now we'll have the Q&A session. Just come up to any of the microphones and feel free to ask a question. Just wait 1 second for both of our panelists to come up and then. Okay, go ahead, please.
Sammy, a stupid quick question. How come I can't get a hepatitis B core antigen? Because the National Heritage Life Insurance Company has declared that this is not an orderable lab in Medicare. Constantly we see it. I'm just curious, where somebody like yourself with prestige and power can't get that thing changed.
So hepatitis B core antigen?
Yep.
Or antibody?
Antibody. No, antigen.
It's available, but only staining the liver. I've never heard of on the.
I'll show it to you sometime.
Yeah, please.
Thank you.
We should write a letter for
We just get it. Just comes up in the EMR all the time, and they just generate, IBNs, and then patients don't want to pay for it.
Okay, we'll talk about that. That's interesting. Thank you, Chuck, for the great question.
Go ahead.
Yeah, what's your thought about just treating patients who are DNA positive for hepatitis B and just leave everything else alone, ALT or AST or liver test, and just if they are DNA positive, just treat them?
Yeah, great question. I want to hear from my colleagues too about this. This is a hot topic now. And people are saying, listen, you have a virus. We have good data that suggests the viral levels, independent risk factor for cirrhosis, liver cancer, liver failure, they're independent of everything else. If you have someone with HIV, you wouldn't sit down and let until they get AIDS or drop their CD4 count. So it's very controversial. I think because only a small subset of individuals with hepatitis B go on to liver disease and injury, and you are required to take lifelong therapy. But I think that is a conversation that's happening now in other circles. How do you feel about that?
Yeah, I mean, I really like your slide on the gray zone because I feel like I see most of the gray zone, and those are the ones that you do a lot of hand wringing. Particularly, if you look at the changes in the upper limits of normal, right? 19, if you have someone of Korean descent, that might actually be lower than 19, even 30. What's the 2 times upper limit of normal? So at least, and maybe you have a fibrometer showing a F1, right? F0 to F1. So I struggle with these cases. Oftentimes the patients are kind of driving that too. They're just like, I'm not going to take a medicine for the rest of my life. So sometimes the decision's easier.
I think also family history, you always want to ask that. Anybody in the family, liver cancer, automatically treat. I have a very low threshold.
I do too. I'll be honest, I think we should get rid of the antigen. And just, what was that?
I treat a lot of
I treat a lot of people too. And we should write a white paper for local hepatologists in Los Angeles, you too.
Yeah, if it were up to me, I would probably treat everybody with a positive DNA. The problem has been getting buy-in from the patients. This week, I had a patient who had a family history of liver cancer and also met all the treatment criteria. And after 6 months, she's finally agreed to start treatment. It's the idea of being on a therapy indefinitely. You don't get buy-in from everybody. But if a patient is willing to do that and they can afford the medication on a long-term basis, I would agree that the threshold should be low. Go ahead.
Hi, this question is in regards to the increase in alcohol liver injury. My question is, why do you think women are more affected?
Yeah, that's a great question. The feeling is related to the interaction between alcohol and potentially hormones, differences in estrogen. Also, the volume of distribution in women are a little bit different than men. And so the feeling is it's related to absorption. So a lower amount of alcohol in women has a greater effect on the liver.
Can I add one thing? So it's interesting, if you look at drug use, hepatitis C infection, it's also rising for women as well, as opposed to men. I think they're way more risk-taking. I blame Uber and Lyft. If you drink a lot of alcohol, you press the button, you're home, and you don't drive anymore. And I think drinks are getting sweeter. They're getting more attractive to everybody, right? I mean, you like your Mai Tai. I saw you last night. I mean,
definitely.
Another one.
That definitely wasn't me.
Sweet drinks.
No.
But Uber.
Thank you.
Up front, that definitely wasn't me. Go ahead at the microphone.
Dr. Dara,
Yes.
I'm particularly interested in the data that you showed with the profound fasting affecting a kind of increased risk for liver injury. I've seen a couple of cases of that. Nowadays, when we're shifting away from using opioids, in inpatient for post-surgical pain, a lot of times we
1
see
gram
patients put,
acetaminophen.
like 1 gram of IV Tylenol Q6 hours. I mean, that's something that we see all the time in
That's
patients.
crazy.
And something we have to comment on when we do consults. But for your experience, how long of a fasting period before we start seeing that increased risk of injury? And if we do see that, should we tell patients maybe less than 2 grams? Should it be, a 1.5 grams or a gram? Like, what's your thought on that?
2 grams is pretty safe, but in terms of the timing, remember glutathione needs that cysteine, so you need to get that from the diet. It's an essential amino acid that you can't make yourself, because a lot of amino acids you can convert to one another or make them from other things in your body. You can make them from carbohydrates, convert things, but you cannot make cysteine. So I would say fasting, a day of fasting is enough to set you off. And also remember, women are smaller, at least with acetaminophen. They come up with general dosing for adults, but my dose and Sammy's dose, safe dose, are going to be different. We're different sizes. My liver is much smaller. So fasting size, and also when you're sick, I think a lot of patients don't realize when they take Dayquil, there's acetaminophen in it. When they take a lot of over-the-counter stuff, is also loaded with it. I think you're pretty safe with 2 grams, and I always tell my patients eat.
Thank you.
Thank you. At the microphone.
So question regarding patients with alcohol use disorder. So I think the lecture talked more about outpatients. We do see a large number. I go to a county hospital, private hospitals, different settings. So we get consulted all the time about patients with alcoholic hepatitis and alcoholic liver disease with mild elevation of LFTs. And I always tell the residents and the students that we as doctors, our main impact when we see those patients, not to order the steroids, not to check the Lyle score, not to check the discriminant function test, is more to talk to the patient personally and say, this is what it is. I mean, just plain, plain daylight. You either stop the alcohol or you die. It's your life on one side of the equation, and it's the alcohol. So you just have to take this time in the hospital and think about a plan moving forward. So my question is about therapies. Do you, other than counseling and talking and maybe finding a rehab program and getting the patient to look into the dynamics at home and social effects that might affect their alcohol abstinence, do you start them on naltrexone? Because you talked about that acutely, and maybe composite as maintenance. What else can we do for those patients to decrease recurrence? Because unfortunately, you see the patient today, a month later, they're coming in with alcoholic hepatitis, acute liver failure. And we've all seen examples, especially in this area, where they just basically succumb to death and be the end of the story.
Yeah, thank you for that question. The first part about your approach to these patients and your teaching, I think it makes a lot of sense from the addiction perspective. You're capturing these patients who are scared, and there is this concept in addiction medicine of hitting rock bottom, which often is the most motivating factor for these patients. So I totally share in your approach to really being honest with these patients and saying, hey, some essential organ that cannot be replaced, besides transplant, which you're probably not going to be eligible for at this point. This is your one shot. You got to take care of it. And that kind of, you can call it scaring the patient, or they're scared already. That it's a good opportunity as a teaching moment, to make that very clear. So that's the first part. I agree with you there. The second part is we need more evidence. I'd love, for you to lead a trial on what it's like to, how starting AUD pharmacotherapy at the time of discharge, how that impacts future liver or alcohol outcomes. That study hasn't really been done, partly because historically alcohol patients are not the most reliable in terms of recruiting and getting them back. And also there's a lot of reticence on the provider end to start a new naltrexone in someone who's just recovering from jaundice, right? Or is still jaundice. Even myself, I'm not, I presented the data that naltrexone is safe, but we just don't have a lot of real world experience in that, in the various forms of alcohol fibrosis, alcohol steatohepatitis, and the different stages depending on MELD score. So I do think you're right. There is a role for that. There is data that came out from the Mayo Clinic very recently saying that patients who, after a bout of alcohol-associated hepatitis, whether they enroll in some kind of behavioral therapy, psychosocial therapy after their discharge within 3 months, that influenced whether they lived or died. Okay, so I agree. Something needs to happen in terms of intervention. What that is exactly is still needs to be figured out. But I do agree we need to try something, and so that's why I'm encouraging the crowd to say, listen, if it's not us, who is it going to be, right? And so I hope I gave some ideas about that.
So what do you do to those patients in your practice when you see them in the hospital? On the inpatient service, what kind of interventions do you do? Do you do anything else other than counseling and
so
in your practice?
Yeah, in my practice, we have a floor social worker who usually provides a list of programs sensitive to the things that I described: location, insurance costs, and language, and things like that. But I also make sure we also have a very big hepatology group at Mount Sinai to get him into the hospital, get him into the office within 1 to 2 weeks after discharge to really have that medical follow-up. I tend not to or shy away from starting medications, upon discharge, because oftentimes either they don't show up or it's a little bit too complicated for them. That's really a more outpatient kind of perspective. In the inpatient, you're focusing on improving liver health and symptoms to get into the outpatient setting, and then that's a more appropriate time where they can kind of focus more on the mental aspects of things.
How about the rest of the panel? Any other? Because it's a very difficult subset of patients that we deal with, and I find it very this is our duty to do something to them, but it seems like we don't have a lot in the toolbox.
I really enjoyed Jean's talk because I'm sure you know Helen Hahn, my colleague. She is very big on treating people for alcohol use disorder and encourages everyone. And I, as a hepatologist, and my hepatology colleagues, we don't do it. So I like that you're even encouraging gastroenterologists to do it, because even we're hesitant. I think we really need to start with the hepatologist in particular, get people more comfortable. And it's because we're not trained in it, right? I've never prescribed it except maybe like Wellbutrin when I was in a resident. So it's not something we commonly do. So, and definitely Helen does it. If I want to do it, I generally ask her, we kind of have the luxury of being able to have very specialized people within our group that do different things. Not inpatient though. We don't start at inpatient. They come to clinic afterwards and they get started.
I just worry that I don't think these drugs work well in a vacuum. I'm not aware of any, let me know if I'm wrong. I'm not aware of any study that shows these drugs work by themselves. They only work in the setting of behavior therapy. And we're not trained for behavior therapy. So what we've done at UCLA is we partnered with the family medicine. There are 2 physicians that just focus on addiction medicine. They come to our transplant committees. My humble opinion, we're not trained for this. Prescribed medication, are we able to deal with the side effects, with the authorizations? We're just not trained. We're not psychiatrists. They gotta be seen by addiction medicine specialists, period.
I will add to that, though, that kind of like doing an endoscopy, the first one is very hard. As you do more, it gets easier. I recently started giving naltrexone 50 milligrams daily to my patients with compensated cirrhosis. And what I found is that the first time I was really worried. I gave all my information to the patient to call me if you have any of these side effects, et cetera. And then I started to realize it wasn't so bad. And so I've started to give that a bit more now. In terms of, is it effective? It's still too early for me personally to see. But in terms of my comfort with it, I do think that the only way you will get comfortable is if you start to do it. And I would start with the patients who are going to be very reliable in terms of following up with you and calling the office, et cetera. But I do, even though I understand Sammy's point, and it's absolutely not in a vacuum, I do think we have to start somewhere because of the lack of access to mental health treatment in this country.
I think we need more data. I mean, I used to do tons of liver biopsies. I've done 5,000. Our ultrasound does a much better job than I do now. I think these people deserve a better chance, and I think that the guys be seen by an expert in this area, by addiction medicine. For the same reason, I don't treat depression. They got to be seen by a specialist. This isn't easy, and there's no data that shows that prescribing a drug by itself does anything. I think they're seen by addiction medicine behavior. That's a whole different story. But these drugs don't work in a vacuum. This guy's got cirrhosis. Oh man, he's motivated, man. He wants to live. He wants that transplantation. But the person with alcohol hepatitis, no, they get sick, they get better, and they're going back to their ways.
Gene, you have a multidisciplinary approach, right? You send the patients to multidisciplinary team, but then you just write the prescription.
Yeah, I agree with Sammy that a multidisciplinary approach
Yeah, you have to.
is optimal, but there are situations where you're under-resourced.
Yeah.
You are part of that process if you really are going to help these patients, you know? And so I think we have to, we shouldn't undersell how our role as a GI or hepatologist in providing that little piece of that esport that you're doing to the patient. There's data for that. You're doing that, even though you're not necessarily trained to do it in a very formal way. So I think if you're, you know, backs against the wall, you know, access is poor, you know, that's why I proposed gabapentin, because I think most people are comfortable with that medication to give that a try as a low-lying fruit to get some experience, because, you know, the landscape of liver disease is shifting. We have to respond to that, right? Whether we feel comfortable with that or not.
How much you start with the gabapentin?
I usually do 100 milligrams TID, anywhere about 100 to 300, depending on the patient.
Cause a lot of somnolence, so if they work during the day, it's going to be tough, right? It makes you very sleepy.
It can be. So I usually start with, you know, the nighttime dose to give it a try to see how they feel. If they feel too groggy, and oftentimes, you know, make it more PRN situational. Because I agree, really, they don't like to take it every day, but if they'll take it before the barbecue or the party, and which is a validated way of prescribing naltrexone, something called the Sinclair Method. Okay, this is something that can be used in more palatable patients.
Thank you.
Thank you. The microphone in the back.
Yeah, so thanks for the talk. So this is for acute DILI Hilly. You see a patient in the hospital, you suspect it's DILI Hilly. You did your diligence, you do all the blood work, you rule out all other liver diseases, you do a liver biopsy. It's not drug-induced the liver injury. It's not drug-induced autoimmune hepatitis. It's not checkpoint inhibitor at this point. Is there at some point, besides liver transplant referral, is there at some point you would throw in ursodiol, NAC, steroid? Is there a role for any of those?
Good question. Good question. A bunch of them have been studied, not specifically in Hilly. Ursodiol, no, I don't prescribe ursodiol except for PBC. I know some people do that out in the community for various forms of cholestasis. I don't. So the acute liver failure study group, and we're talking about, if you're talking about NAC, you're thinking about acute liver failure. You're not going to give NAC to somebody who's not in liver failure. But the acute liver failure study group looked at patients who had non-acetaminophen liver failure. And these were patients who had hepatitis B, drug-induced liver injury, and so on and so forth. And those that presented with grade 1 or 2 encephalopathy before they become very encephalopathic, right? So there may be a little bit memory loss and a little bit confused. Those patients, if you give them NAC, they actually do better, whether it's from Hilly, whether it's from HDS or something else. So any cause, acute liver failure, will benefit from NAC. So generally, even if people are encephalopathic and not from acetaminophen in the practices, we put them on NAC. And steroids for drug-induced liver injury, not specifically for HDS, have been looked at, and they don't do much. So we don't give steroids. They, risk of infection.
And by the way, the NAC in non-acetaminophen with the acute liver failure group,
yeah,
we published that a few years ago, and the survival increase, particularly if you start early.
If you start early,
we have patients that come in the emergency room, jaundice and encephalopathic, and we get called as a pathologist, 2 or 3 days later, and it's sometimes kind of late. But question I have to Sammy and the panel is about the 6 months exception for 6 months abstinence of alcohol before liver transplant. And I think, Sammy, you're going to comment probably on the new change in Medicare. Patients with great family support, first time come to the hospital with liver failure, and they are very motivated to stop. First time they were told alcohol was a problem. They were functioning alcoholics with the job and everything. So,
I think most of us all have from institutions where we don't longer follow the 6-month rule to the letter. I always felt that it was a ridiculous idea. Basically, you're telling someone, man, if you're lucky to live 6 months, you get a transplant. If you're not lucky, oh, I'm so sorry. So I think it's a group. I think we're a little smarter now, understand that there are better predictors of drinking, like you mentioned. First time, goes family support, having insight. At UCLA, and I'm sure similar at USC, only a small fraction of people that come in with alcohol-hepatitis fulfill this criteria. I don't know, 20%, 10%. So, but we don't, time is no longer
We evaluate them.
Yeah,
Yeah.
we always do.
Yeah.
Yeah. How about
And
your
to USC particularly with Nora and Brian Lee. I mean,
Yeah,
they're
their
case studies.
SALT score. All the residents are doing SALT scores now. It's really funny. That's Brian.
Yeah, thank you, Lorenzo.
Thank you. And along those lines for our last question, because the criteria for transplanting alcoholic hepatitis patients is really not standardized. Just for each member of the panel, can you just discuss briefly, what do you use to determine if a patient would be transplantable or not? I'll start with Gene.
Yeah, I mean, there's some comments about how it's very subjective, right? We're just kind of making up the rules as we go along. But I would argue that it has been there's a consensus document called the Dallas Consensus Conference that was published a couple of years back in liver transplantation, where there were some things that rose to the top, and I think some of this has been discussed before. So. First liver decompensating event, even though it was an empiric criterion, meaning no prior history of jaundice, alcohol-associated hepatitis, alcohol-associated pancreatitis, many DT episodes in the ED, frequent flyers. Those are not the patients that we're that interested in, who will likely do well as of right now. Okay, patient having very good insight. They're coming to you saying, I'm going to die. I need your help. These are not patients who are just like, I think it's maybe from the statin that my doctor gave me. I still think it's something else, So they accept their diagnosis of, alcohol-associated liver disease. And support is very important, but you're not transplanting the family, you're transplanting the patient, right? So I think that's actually kind of lower on the list. I think most people will have someone who will stand up and help, but really acceptance of the diagnosis, someone you can work with, someone who hasn't had many, relapses in terms of multiple rehab stents. Those are the things that rise to the top in our program.
Are you guys doing anything similarly or differently at UCLA?
Similar, but we put family support a little higher. Not necessarily family support, but family also insight. It's a big red flag when the family says, "Oh, I didn't know my son was drinking," or "Oh," those people always go back to drinking. But the same criteria that Lorenzo mentioned, you mentioned too, Gene.
What about at USC?
Very similar. We actually do calculate a SALT score because Brian very much teaches the residents to do it. And it's the same stuff, just basically scored. And the other thing I would say is that I practice at the county, and we don't do transplants at the county. So I sometimes refer to Cedars, I refer to Sammy, depending on the patient's insurance and what HMO within the county they fall into. I can't always send them to CAC. And I've found that in the past year, I have a much easier time sending people to you guys. So everyone,
I was thinking the same thing. I get some of Vinay's patient. I get some of yours. You get some of my patients, and it's something they accept them.
Yeah. And sometimes, sometimes I have a conversation and I talk to somebody, and they say, "Yeah, I don't think this patient's going to make it here," and then I call somewhere else.
Yeah, it helps.
Yeah,
like people we denied.
Yes, we transplanted somebody who was denied at UCLA, and she's doing well.
Vice versa, we have someone on the list that you guys didn't accept, and it's pretty fun. Even though we have the same criteria,
yep.
Still within a.
I think you also have to get somebody who kind of believes the patient.
Yeah,
and is going to fight for the patient.
Everybody needs an advocate.
Yeah.
Oh yeah, that's the most important part for the
There's data that just got published this month that suggests that for listing purposes, at least, there are 99 programs out of the 200 transplant programs, liver transplant programs in the United States that have listed someone for acute associated hepatitis, alcohol associated hepatitis. So that number used to be, less than 1%. Now it's almost 50%. So I think
I give Felipe Matherin a lot of credit for that. He really reinvigorated that debate. Yeah.
Where is that published?
In Transplantation, I think from the Philadelphia.
Oh, good. I'm sure that.
Okay, and we are out of time. So I want to thank the panelists and speakers as well as the audience. Thank you very much for your time. And we have our post AASLD symposium in December, and have a great weekend.